Welcome to Safest Talks, a space where experts share evidence, clinical experience, and practical insights to advance safer, high-quality patient care. In today's episode, we explore how multidisciplinary training and teamwork contribute to safer perioperative care. This episode is based on Safest Standard SQ6, which promotes regular specialized training for surgical teams to strengthen patient safety, teamwork, communication, and continuous learning. By learning from serious incidents, adverse events, and patient feedback, healthcare teams can continuously improve their practice and help prevent future harm. Today's guest is Dr. Paul Barach, professor, clinician-scientist, and expert in patient safety and healthcare systems.
Hello, my name is Dr. Paul Barach. I'm a professor of anesthesia and critical care. I have been working for the last 25 years as a researcher, as a clinician, as a former chief medical officer, as well as a head of quality and safety in a major academic hospital in the US, the University of Miami, as well as I've worked in Europe, Australia. And I've been very, very passionate about this first podcast, which I'm doing on behalf of my good friend, Carola Orrego, who is the principal investigator for this project, for the project Safest. So I'm delighted to talk with you today for this first of two podcasts on standard SQ6 on surgical teams are provided with initial and regular specialized training. So this is a topic which has been close to my work and practice for a very long time. And so I'm delighted to talk about why we need multidisciplinary training.
Why is multidisciplinary training so important in perioperative care, and how does it contribute to improving patient safety and teamwork in daily clinical practice?
We know that most adverse events in all industries and also in the hospital and primarily in the operating room aren't technical failures, or mostly non-technical failures. And as such, they often relate to coordination breakdowns, failed handoffs, hierarchy-induced silence, psychological danger, fragmented situational awareness, lack of mutual support, and ultimately loss of the overall flow of events. The environment in the OR is dangerous. Complex social technical systems have danger that emerges all the time. The surgeon, the anesthesiologist, the nurse, the scrub, the circulator, all of them are working under pressure, time pressure, and performance cognitive load pressure. This means that it's hard to predict when things will go awry, and when they do, are people actually ready to work with them? And so other industries like aviation and nuclear power and the military have designed structured cross-training opportunities where different disciplines work together, train together, both in real situations, simulated situations, with the idea being that they'll be able to understand and predict when each other will behave and how they'll perform under pressure. In my own research over 25 years on team training, near-miss reporting, and team leadership, which led to Team Steps, which a group of us helped create 20 years ago, we argued that ultimately the communication, coordination, alignment, and trust between team members are essential in order to create an environment that's harmonious and supportive, in order to get the best opportunities where people feel comfortable leaning in, speaking up, and ultimately being able to have their back covered. So they're not afraid to be vulnerable. They feel deeply engaged. And so we know that this idea of cross-training is essential, because the work in the operating room is a team effort, it's a team engagement, and requires many more aspects that are not traditional only knowledge. They're knowledge, skills, and attitudes. So this is really the structural foundation for high-performing, highly reliable systems. And as such, the operating room needs to move towards that. And that interrelated interconnectedness is at the heart, not just of better care, I think, but also of nurturing environments which lead to better resilience, more joy, more loyalty, and less burnout.
From your experience, what types of training are most effective in strengthening communication, openness, and collaboration among surgical teams?
Over the years, over 25 years, we've worked on a variety of modalities in order to address these core competencies. We've used simulation. I used to run the University of Miami Simulation Center for many years, one of the first in North America, with structured debriefing, which included high, medium, and low fidelity simulation, allowing us to recreate high-stakes, low-frequency events, and ultimately borrowing from aviation, crew resource management or crisis resource management, which essentially teaches us a variety of skill sets. Number one, no surprises. The team members know what to anticipate. Number two, we declare emergencies early. We call it out, we name it out. We distribute the cognitive load, so we have very clear roles and responsibilities, as I'll share in just a moment. We close the communication loop, so we confirm what's going to happen. And of course, we use clear debriefing to understand where the real learning lives. One of the examples that we've developed around this years and years ago is that when there is a crisis, we immediately acknowledge what's happening, what is the expectation, and so everybody knows that, and then the expectation is that other people will either accept it and go along with it, or if they disagree, they can challenge it, but in a very clear and explicit way. Team training, which essentially was an iterative environment of teams using the CRM framework, was really about this idea that it wasn't just a one-time training, it was a foundational training, but then because of natural skill decay, and de-skilling, team rosters change, organizational pressures, there had to be an iterative cycle of training embedded in the clinical workflows. So thinking about how best to think about the workflow in the OR, using the SEEPS model, using Donald Norman's idea of work as is versus work as imagined, reflecting back on Eric Hohenagel and Jens Rasmussen. All these thinkers really helped us think, both in Europe and in North America, showing that sustained improvement happens with repeated contextualized exposure around these themes. It's very clear that structured after-action reviews in real clinical settings is key. So we've been using simulation that way for decades, borrowing from aviation, realizing that we need to talk about what went well, what didn't go well, what could be improved. Depending on how much time we have, it could be sometimes between cases. We've done this with 1 minute, or longer in the simulator where we have 15, 20, 30 minutes. It's clear that all debriefing and all learning can only happen well if there's psychological safety. That means that younger people, more junior people, everybody feels comfortable speaking up. The openness, the vulnerability is not a personality trait. It's a function of the professionalism in the environment where the leaders create a space to speak up, to push back, to improve. That means that when senior leaders say, I made a communication error today, it dramatically helps to change the environment. So again, just to reflect on that, Team Steps as an evidence-based, competency-based model, looking at knowledge, skills, and attitudes, and the metacognition that comes with that, supporting each other, mutual trust, closed-loop communication, and all-around sound human factors principles.
As technology becomes increasingly present in operating rooms, how can healthcare professionals be better prepared to safely manage equipment and new technologies?
Another key theme that I was asked to address, of course, is the role of technology and how technology plays a role both in the SEEPS model as we think about the interfaces, the Donald Norman approach to how the design of outcomes is predicated on how we design the system. So the people who design the operating room tables, the surgical robots, the anesthesia machines, all these people create the conditions for success or failure. Technology introduction has consistently outrun the training infrastructure. So robotic platforms, AI-assisted imaging, integrated OR systems, they're all great ideas, but we have not advanced nor required the educational paradigm to follow that. In aviation, for example, when we have too much automation, we've learned about automation complacency, where over-trust of automated systems has led to under-monitoring for failure modes, and often early signals of deterioration are missed. And some of the data from surgical robotics has shown that these early signals can be missed because of an overemphasis on the technology solution. We know that in order to make sure that technology enhances the performance of these teams, effective technology training must do several things. Number one, scenario-based, not here's how the robot works, but under what conditions when it fails. For example, if you have to de-dock, what are the steps? De-docking right now is still widely variable. There is no common standard. So this is an example where the robot has been in place for 10, 15 years, but the companies or the regulators have not led with requiring a minimum level of a rehearsed crisis response. We also know that we need to be multidisciplinary. So robotic training should include not just the surgeon, it should include the surgeon's assistant, the nurse, the anesthesiologist, technicians, because technical failures often require coordinated team response, not just the surgeon response. And of course, it needs to be continuously updated with changes in technology. That means the training is built around the last year's platforms might be inadequate for today's devices. Clinicians also need to be critical of how the technology is being used, understand what the assumptions of the designers are, what the evidence base is, and what the limits. This is not skepticism, this is patient safety.
What impact do you see when surgical teams receive regular specialized training, both in terms of patient outcomes and the overall culture of safety within healthcare organizations?
Finally, I want to talk a little bit about the impact on outcomes and safety culture. We know consistently across other industries that before-after studies and observational data show that reduction in complications, wrong side events, retained objects, unplanned return to OR, all of these are tightly correlated to non-technical skills of communication and coordination. The strongest effects when the technical and non-technical skills are combined, so we don't do one or the other. We train on robots, and then in parallel we train on the non-technical skills required for the surgeon to communicate with the anesthesiologist, the nurse, the technician. Parenthetically, designs that take the head of the surgeon away from the field, for example, the Da Vinci robot, is an example of poorly designed human factor principle device because it means the surgeon doesn't see other people, the people around them don't see them, and often that leads to opportunities for miscommunication and lost early signals. We know very clearly that a culture of safety in the OR predicts better outcomes. It's not causal, it's a marker and association. We know that better effective leaders produce better outcomes. Conversely, toxic surgeons, toxic leaders produce worse outcomes. We've seen this in aortic aneurysms, in general surgery, in pediatric cardiac surgery. Every field that looks at it finds these similar findings. The corollary is that if you want a high technical environment to succeed, you have to focus on leadership. That means training anesthesiologists, surgeons, and nurses in leadership and followership. That means the development of individuals is not just about their technical skills, but their ability to integrate with a continuous growth pattern. That signal changes how people relate to error. Near misses get reported rather than hidden. Dysfunction gets named rather than worked around. Training done well becomes self-reinforcing, and experts want to be trained. They want to improve. They want to learn better. The culture improves, and it's a virtuous cycle, if you will. We know that the error is rarely where we think it is, but it's often deeply embedded upstream, and then the error manifests. So instead of jumping on that point, we have to go upstream and understand that the safety is not the absence of failure, it's the presence of an adaptive capacity to identify the telltale signs and to come together not just for competence, but to come together for resilience.
If you could recommend one action that healthcare organizations could implement tomorrow to make perioperative care more environmentally sustainable, what would it be and why?
So I want to wrap this up, this short podcast around SQ6, that we need to start every day with psychological safety. That needs to be a backbone of the training, needs to be part of the timeout interaction at the beginning. As you may know, a lovely project in Switzerland right now called STOP is showing clearly that even stopping in the middle of an operation, any team member can call a stop, and for about 1 to 2 minutes, we just check in. Here we are, here's what the plan was, here's what's happened over the last 30 to 40 minutes, here's what we're expecting next. That seems to be seen to reduce adverse events. All the simulation, all the checklists, all the technology training in the world will not protect patients if team members don't trust each other, if they don't feel that their back is supported, if they don't feel they can speak up, and if they don't feel that their voice is listened to. We know that very clearly, that more patients die around surgery when nurses are disregarded or not acknowledged in their expertise. Building that environment of trust, a culture of safety, is the single most important element for enhancing surgical resilience. The harmony, the trust, the willingness to support each other in times of crisis, that is so much more important than more technology. And perhaps as a reflection for that, in spite of all the technological improvements around the operating room, we have not seen a commensurate reduction in adverse events. And that's something that we need to really think about carefully. In closing, I want to wish you success for this remarkable project, in particular as it relates to strengthening and supporting the recommendation of SQ6, which essentially speaks to the fact of how do we regularly integrate and require multidisciplinary training as a foundation for a culture of safety in the operating room. Thank you so much for your attention. I wish you all the best with the follow-up of this project. Thank you.
SAFEST is a Horizon Europe-funded initiative dedicated to advancing safer perioperative care through collaboration, innovation, and shared learning.